Thank you for having me on this course again this year. Ectopia, I will choices. Now, I think it's pretty. Yeah. So, I think I'd rather give you an algorithm. One is you have a capsular bag which is okay. You have a progressive zonular disease. Do not use the capsular bag. People have done heroic surgeries, single Sioni ring, everything. 3 years down the line, 5 years down the line, 10 years down the line, if the lens with the bag sinks, it's not worth the effort. So, Marfan's, homocystinuria, pseudoexfoliation, I think you must make your choices. Capsular bag is okay. It's a traumatic iatrogenic zonular loss, less than or equal to 1 quadrant, a multi-piece or single piece IL with a CTR. 1 to 2 quadrants, CTR plus multi-piece IL. You can still, till 2 quadrants you can happily manage. I think 2 quadrants onwards, I think you should start thinking of a Sioni ring with a multi-piece or a single piece IL. And I think if it's 3 quadrants, either you put a double Sioni ring or treat it as a capsular bag, which is not okay. Now, if the capsular bag is not okay, we have options of sulcus placement with a larger diameter lens and larger optic diameter. If you can, you should not try over here. Even if your axis is all right, I think optic capture is not advisable because your entire lens will be decentered. A sulcus black placement again would not be preferable because it's likely to be decentered. You'd rather go for a scleral fixation. So you have sutured, glued, iris fixation, posterior iris and anterior iris claw lens. So, and the ACIL. The ACIL is not so bad, as I'll show you. Now, we have a multi-piece IL over here being put in a traumatic subluxated cataract. This is an 8-year-old child. We had a traumatic subluxation. Actually, there was no phacodonosis, and I discovered the subluxation on the table. In my pre-op examination, the pupil never dilated so much. And on the table, I had a fantastic dilatation. And I noticed the subluxation, so I went ahead. And I'm trying to show something. Actually, the rest of the surgery is nothing great, and unfortunately, this video is there as it is. I can't probably... Yeah. So put in the CTR. What you see, this is an open CTR. These CTRs tend to be less rigid. I don't know whether it was a very wise choice to use this CTR compared to the rigid ones. I have covered the entire circumference of the bag, and the CTR is nicely inside. After I remove, why I would probably prefer a multi-piece IL in certain situations is, like I'll show you over here. See the CTR margin, I can still see the CTR margin over here. The pupillary dilatation is almost equal. So I chose to put in a multi-piece IL. And the lens goes in. I still can see my CTR margin. There's no viscous coming over here. That's fine. I still choose to put my haptic in the subluxated area so that I give some more capsular support. And if you can see over here, you can see the CTR margin and the haptic margin. See, the haptic is going outside the CTR circumference. So I suppose my haptic, though my lens is still a bit decentered, but my haptic is still giving me more support than the CTR in this place. So I would probably choose a multi-piece IL. Now, this is a case which went bad. This was put in, I made an absolute mess of it, and looked very stupid actually. In the process, I got a Sioni ring which was totally entangled, and now the more traction I put on the sutures over here, the Sioni rings moves away from the sclera. So it was a very unhappy situation. I was really at my wit's end, and I tried removing this, getting this disentangled and everything. As luck would have it, I was not very lucky, and eventually I pulled out this suture with a lot of trouble, and I lost the entire capsular bag. So I had a Sioni ring with the suture in place and a lost capsular bag. So what next? I could have pulled out the Sioni ring, but the traction on the vitreous base that it would cause probably some giant retinal tears or horseshoe tears for sure. So I chose not to remove the Sioni ring. I left it behind, and that was on the table improvisation. I chose to put in a multi-piece IOL over the Sioni ring and do a transscleral fixation of the IOL. Make sure that the sutures went taking the Sioni ring and the haptic of the IOL, so that my Sioni ring as well as the IOL were secure. One end of the Sioni ring is definitely secure. Now this is when I finally managed to disentangle the Sioni ring. There you are. I got it, but at the cost of my capsular bag. Now the Sioni ring goes to the wall. Okay, so now I did a transscleral fixation and I tiled this haptic over here, and I placed the other haptic actually within the Sioni's hook part, because that part of the Sioni ring was secure. So I had a single point fixation of the IOL, and it was merely placed on the Sioni ring over here, but the overall diameter of the IOL was good enough to keep the lens well centered, and it was anyway fixated in one place, so there was no movement, and this patient has been seeing very well. Now we're coming to iris suturing of IOLs. This is a modified Seeps's knot. You can just look through this. There's a first bite taken, make a loop for the shorter segment, pass the free end, and pull the knot into the eye. This is a subluxed lens, so these are choices you can use. You can implant a lens and then have a pupil capture and then go ahead and do that. This you would probably do from this stage in a ectopia lentis. Make the side ports. Pass the straight needle. It's a good idea to always bend the needle a bit so that you have, yes, you take the bite with the haptic. There's a bit of bleeding because I touched my needle overshot a bit. Hook out this loop. Take the shorter end of the loop. Take the shorter end of the loop and make multiple throws, and then pass the free end of this suture and make a knot. This is a slip knot kind of thing. And then you draw the knot inside. You're drawing the knot inside. There goes the knot inside. And you tighten the suture. Now the key features over here is not to take a very big bite of tissue, then you'll have the haptic slipping out post-op much later, and not to make the suture very tight, you'll have cheese wiring of the tissue. Otherwise, this is a very safe procedure. Since you're damaging the blood aqueous barrier, it's a good idea to use Nepafenac drops for a period of 3 months. I do that regularly. In fact, I have a poster this AIC on this. So this is the other haptic being sutured in similarly. Downside is that you'll have a slightly oval pupil in the first month or so, or first few weeks of the surgery, which eventually becomes definitely not round, but less oval over a period of time. It looks like a cat's eye initially. That's maybe a slight cosmetic problem if the patient looks very closely into the mirror. But I guess it's better than having no IOL over there. That's how it looks on the first day, and after some time it looks much better. With a bit of pupillary dilation, it eventually settles down. These are the sutures you can see. Scab bag knot. Okay, this is a case where I'm doing a vitrectomy now, and we will be putting in an AC IOL. Recent literature suggests that AC IOLs perform as well as iris fixated or transsclerally fixated IOL as long as the job is done well. The part of doing the job well is doing a good vitrectomy. I have a minute more, so I'll finish. So we do a good vitrectomy, inject pilocarpine. A good idea. See, you can see a small strand of vitreous over there which is bothering me. I try to sweep my spatula. We don't want to be very vigorous, but then I do a use the cutter, and you see the pupil becomes round. There you are. The pupil has become. So any strand of vitreous has to be cut. It's a good idea to use triamcinolone acetonide. It depends upon your comfort level. If you're sure that there is no vitreous, you may choose not to do so, but it's always a good idea to do so. And viscoelastic. Now enlarge the wound to the size, which would be about generally 5.5 would be the optic size. A Kellman multiflex IOL is possibly the best AC IOL that's available. Iris claw lenses, I don't have any experience, and there are different reports. So once the AC is well formed. Now what is most important about this? One is doing a PI, and this I'll just take half a minute. And this is to see the anterior vaulting of the IOL. See, your PC IOLs are posteriorly vaulted. AC IOL has to be put in with an anterior vaulting. See, this is the anterior. This is the anterior vault. This is the anterior vault. So this lens has to go in vaulted anteriorly so that there is no pupillary block. So you do a PI, and these lenses are meant to go anterior vaulted. Remember that. I have seen quite a few AC IOLs with trouble simply because they were put posterior vaulted like we put our PC IOLs. Trailing haptic goes in, a real leading haptic goes in, and the optic, and the trailing haptic is tucked in. Be very sure to tuck in this under the lip of the posterior lip of the wound. Sometimes you leave it at the wound also and suture it in a hurry. Don't do that. And you have a well centered lens. Tuck it in with the Hirschman, initially with the McPherson, and then with the Hirschman you can easily tuck it in and position your haptics. Just show you a few post-op pictures. Yeah, this is a post-op picture, looks very good. And if you've done a good ACIL, I think they survive the test of time. Thank you very much.